So I think the more important question is, if the patient on the right side is MSI high, so what would you be doing then for liver limited disease, Amish, are you there?
Yes, sir. Yes, sir.
So what about immunotherapy as compared to induction chemo, with or without BEV or whatever you think?
Sir, we'll discuss with patient. NCCN says it can be used. I would discuss with patient. I am CRC, MSI high, very good data, sir. Of course, this is all in the unresectable, but sir, hardly anybody has relapsed after 2 years.
Great. So I think those are the questions which are emerging now with the availability of immune checkpoint inhibitors, and seeing very, very robust responses in patients who are MSI high. However, as you know, in colon, as I discussed in GI, the MSI high status is rather low in terms of its incidence. So I think I'll just, a lot of things have been said by Amish. So I'll just, close in a few minutes. I'll just cover the relevant slides. So these are the headings in which we will sort of discuss these issues. So I think, as we know, the MSI in colon cancer is seen in about 15%. Next slide, I think, is going to highlight that problem is that if you go to the metastatic setting, it comes down to 5%. And that is where the drug is possibly, most effective. And these are certain subtle differences in the biology of MSI high and the chromosomal unstable kind of disease, which is much more common. So the problem is, you will, in your practice, be very lucky to find a patient with metastatic disease who has an MSI high tumor. So next slide. So I think I'll just cover this point subsequently, that we need to do the test. So next slide. So this is the other issue, I think, which was, I think Dr. Amish covered, which was the mutations, a number of mutations per tumor. So as you can see, the colon is again, if you look at the sporadic adult solid tumors, again, you don't find too many patients with high tumor mutation burden. Next slide. So this is what I just said. MSI is 5% high in metastatic colorectal cancer. Mostly it is MSS. And this is what I was alluding to when I, in the previous talk. So it is not only MSI high with the high immunoscore, but even if somebody has MSS but has a high immunoscore, so these are the patients, who tend to perhaps benefit or have a better outcome in terms of prognosis. So I think as I was discussing in the stomach cancer or the upper GI cancer, adenocarcinoma, so you need to have some kind of score which could identify these patients who are eligible or who could benefit from these, simple, safe, although expensive immune checkpoint inhibitors. Next slide. So I think that is how the thing has evolved. As you know, this is the NEJM publication where solid tumors with, MSI high showed the benefit. And if you were to look at the colon cancer patients, which is in the blue bars here, so they really, really, benefited as opposed to the proficient MMR. Next slide. So I think this is the same slide where you can see the response rates 52% and a disease control rate 82% in colorectal patients. Next slide. And a similar benefit was seen irrespective of the tumor type. And as was being pointed out, so they really have overall survival, which is not reached. Next slide. So that's the beauty of these immune checkpoint inhibitors. And not only for pembrolizumab, so this data has also been shown in the pre-treated patients in second or subsequent lines with a combination of Nivo Ipi. And however, Nivo alone doesn't seem to give you the benefit. Next slide. And that is the Nivo Ipi, which is seen here, giving you the benefit as you saw with pembrolizumab, and overall response rate of 55%. Next slide. So this is the other drug which has also been approved, which is the dostarlimab. And again, you can see response rates to the tune of 50%. And this is approved in August 2021. Next slide. So I think with this, the NCCN guidelines, as was shown before, Nivo-Ipi or Pembro is approved in patients with deficient MMR or MSI high alone, and in the first line. So and patients who have not received therapy. Next slide. So I think it is as was shown before. So since we are running really short of time, I'll rush through. So I mean, this is now coming to again. I think this data I've already shown. We'll just skip these slides. Next slide. Next slide. I think. So now coming to the first line. So second line, of course, the data is approved. But I think in the keynote 177, Pembro showed the benefit. Next slide. So I think these curves are really self-explanatory, and everybody is aware of these curves for PFS1 and PFS2. Next. And again, the overall survival, fantastic. You see the response rate in the first line of 70%. Next slide. And you see similar positive outcomes with the combination as you saw in pre-treated patients. And this is the first line data. Next slide. And so I think both these combination and the single drug of Pembro is approved. So then, if you have a patient whom you have not treated before with immune checkpoint, so there is data for two combinations. Next slide shows you Nivo with regorafenib, and you can expect, and this is again, you see for proficient MMR or MSS CRC, especially patients who don't have liver metastasis, one can expect a response rate of around 21% and a median duration of stable disease for 30 weeks. So this is a combination which one can think of using in your patient who are really desperate after the failure of chemo. Next slide. And the LEAP study, which had Pembro and lenvatinib, again gave you a similar kind of a response rate to the tune of 22%, and a duration of response not reported, but the overall survival around 7.5 months. And these are heavily pre-treated patients. So I think Lenva Pembro is also a viable option for such patients in CRC who are proficient MMR. Next slide. So I think you can see these looking at the response rates. Next slide. So I think this has become so very important now, as was highlighted before, that all patients before they enter into chemotherapy or for systemic therapy, they must undergo the testing. Next slide for MSI or mismatch repair. So I think these are the guidelines at this point in time that you have to have universal slide. Next slide, please. I think just states that you have to have MMR or MSI testing for all newly diagnosed patients with colon cancer. Next slide. So just a word about the testing. So you have two methods for testing: PSR-based tests for MSI, and IHC is looking for loss of expression for one or more of the MMR proteins. So one can do either of them. Next slide. And I think the next slide, please. So I think the IHC-based test is looking at the MMR protein, and the PCR on the tumor DNA is looking for the MSI. So they are both sort of synonymous. So a deficient MMR is synonymous for MSI high, as you all know, and proficient is synonymous for MSS. So I'm not going to the details of this. Next slide. So I think IHC for MMR and the PCR for MSI is kind of equal, and one can do, this is the more widely prevalent, but this you can do by PCR or by NGS testing. Next slide. So I think the next slide, please. So I think these are all, so I think as I mentioned. So next slide. So neoadjuvant studies. I think this is an important area of research, as was, I think, earlier touched upon by Amish. So this is for dostarlimab, a short, small number of patients, 13 here. And this is done for MMR defective, which is MSI high, rectal adeno. Next slide. And interestingly, as was seen before, and you will see in the next slide, 100% patients had an overall response rate, and a complete clinical response was achieved in 100% of patients who completed the induction treatment. So this is extremely encouraging, data for. But the problem, as I showed you, is that the number of patients you will get will be few. Next slide. So this was the. So I'll skip this. Next slide, please. Yeah. So this is from Chalabi et al. For neoadjuvant immunotherapy in MMR proficient and deficient. I'll just read the abstract. Next slide. Next slide, please. Yeah, just show the previous slide. Yeah, the previous slide. Yeah. So if you see, focus here. So if you, they had 40 patients, odd patients, and 20 were deficient MMR, and 15 were proficient MMR. So if you look at the pathological responses, 20 out of 20, and in the deficient MMR, 19 major pathological responses were seen. So this is very, very encouraging, in contrast to proficient MMR, where only 27% patients had responses, and only 3 out of 15 had major pathological responses. So I think the data for colon cancer also is extremely encouraging for neoadjuvant therapy, which one could consider doing, but I think more trials are needed in that direction. Next, a word about pseudoprogression. This is again from Andre et al., where they reported. Next slide. Nearly 30% patients, or some patients who reported pseudoprogression at 5.7 weeks. So the median time for pseudoprogression was 5.7, and so you really have to be careful. And can I have the previous slide? So I'll just read the last line. Patients with MSI, they experience pseudoprogression. It occurred within the first 3 months and represented most of the primary radiological progressive diseases. And the use of iRECIST criteria should be questioned after 3 months. So I think this is important to understand, that I think we sort of tend to ignore if the patient is doing well for pseudoprogression. Next slide. However, the other study, which is Nivo-IPI, next slide shows that they did not. It's very rare. Pseudoprogression is very rare when they use Nivo-IPI. Next slide. So these are some of the miscellaneous slides to show, I think, which is what Dr. Amish was referring to, that patients, if they have BRAF or RAS, they don't tend to get that much benefit as compared to patients who are MSI high. So I think this is the confounding factor for the responses to immune checkpoint inhibitors. I think the subsequent slides are, next slide, are covering, so I'll skip this. Next is the potential of trying to do MEK inhibitors like cobimetinib along with atezolizumab. So I think people are trying various combinations, as I showed you, for LEAP study and for regorafenib. So I think people are trying to look at various combinations with immune checkpoint inhibitors. Next slide. So I think I'll just skip these slides in the interest of time. So this is the other thing which was being referred to, which was the tumor mutation burden. And next slide shows that patients with the colorectal cancer, you can see colorectal cancer. So the median, TMB is around 11 or so. So these are candidates, but if you look at the endometrial, they are the best responders. Next slide. So it's a tumor agnostic marker, especially if the TMB is more than 10, although the data, some people say it is more than 16 or 20. So this is the relationship between MSI, TMB, and PDL1. As you can see, TMB is high in 8.1%, MSI is unstable in 3%, PDL1 is positive in 17.6%. So I think you do have a small group of patients who could be having high MSI or high TMB who tend to benefit from PDL1 has not really, beneficial alone by itself. So I think the last slide. Yeah, so I think we are there. MSI high, if the high tumor mutation burden is there, it can predict responses to checkpoint inhibitors, and the NCCN guidelines for MSI high and TMB high are there. And not only approved in second line, but also approved in first line now. combinations are approved. So I think the new combinations are still being evolved, whether it is with chemo or in the neoadjuvant setting or with the other MEK inhibitors, etc. So thanks a lot.